So not that I wouldn't talk to the parents, but I maybe wouldn't talk to them for half an hour to 45 minutes. That has completely changed as a mom, because I know if I was that mom in the ICU and I had no medicine in my brain, I would just be sitting there shell shocked.
There are many reasons that they can be admitted to a hospital, but tell us more about common reasons why they can end up in the pediatric ICU.
Top 5 reasons are respiratory failure, respiratory failure, respiratory failure, respiratory failure. Common types of breathing problems we see are from viruses, as I mentioned. On rare occasions, they can be caused by bacteria. And for most kids that enter the ICU for breathing issues, they are on what's called high flow nasal cannula, one prong in each nostril. So that allows us to deliver more oxygen at a higher rate, and it's nice and humidified. And I would say 80% of the kids just need high flow. Then we step them down to normal nasal cannula, send you to the floor, regular pediatric floor, and then they go home.
Today's guest is Dr. Anita Patel. She is my social media colleague, an attending in pediatric critical care, an associate professor of pediatrics, double board certified in pediatrics and pediatric critical care. That's a lot to say. Passionate about research and teaching parents to incorporate evidence-based medicine into their children's lives. And I'm so excited to have her finally on after 4 years of this show, because we're going to be talking about the top reasons kids end up in the pediatric ICU and how she manages health anxiety, seeing what she sees, and how I manage health anxiety as a general pediatrician. Thank you so much for joining me today, Anita.
Well, I am so excited. And as Mona said, this is a long time coming.
Well, you were kind of busy in the pandemic, just a tad, managing MISC and all the other things that we were seeing. Oh my goodness. So I'm not surprised that it took forever to have this happen. But I'm grateful, I love that we're going to talk about this. It's stuff that I hope parents never find themselves in. I know you can relate to that. We hope that you never listen to this and you end up in the ICU for your child, but we also want to have expectations and what happens there. And, Anita is one of my most favorite pediatric ICUs follows on social. And so it had to be her that came on. So thank you again.
Thank you. Thank you.
So tell, for anyone who's not familiar, tell us a little bit more about yourself, your training, or whatever it is that you want to share with why you do the work that you do.
Yeah. So, I'm one of those weirdos who's wanted to be a doctor since I was 2. I feel like you're actually similar in that respect.
Yes,
so maybe we're both weirdos.
We're both weirdos.
Yeah. And then I actually got into research also really early in my life. I started in high school at the NIH and loved it and kept going. So exactly what you said, I did my residency in peds and my training in higher training in pediatric critical care. And then I really did a lot of research. And so I'm really lucky now in my current job, and I've been an attending for almost 8 years now, which is crazy to say. But I have a great mix of clinical care, as like right now, I happen to be in a hospital. And I also get to do a lot of research. I have an NIH grant to study ways in which we can augment our care using artificial intelligence and machine learning. So it's great. I get to do everything from the bench to the bedside, or the computer bench to the bedside, I guess.
And then, besides that, you have 2 kids.
I do. And
oh, man.
Yeah. That's one of the Mona and I both had our kids vary at similar times.
Yeah.
So we definitely had text chains many times lamenting about our challenges and successes of having
we have children
parent.
Similar ages. We also had like fertility struggles. We've done
IVF.
I feel like you're my such a good friend, even though I haven't met you. And
I know.
Again, I wanted to have this conversation, not to scare families, just for families to be more informed about what they can expect in the pediatric ICU. And I know you see so many things, but of course there are many reasons that they can be admitted to a hospital. But tell us more about common reasons why they can end up in the pediatric ICU.
It's a great question. And I will say the top 5 reasons are respiratory failure, respiratory failure, respiratory failure, respiratory failure. So that sounds really dramatic. And so to parents, I want you to know that I know I'm using the word failure, but we use that term really to describe a wide range of breathing issues. And, you guys hear both Mona and I, and basically every pediatrician on social media talking about viruses and how to, they're inevitable. So I always tell parents, because the first thing they say when they come to the ICU is, oh my gosh, I wish I could have done something more to prevent this. And the first thing I say is there is absolutely nothing you can do. Even if you put your kid in a bubble, in a room, in your house, they're eventually going to get a virus. So It's not an if, it's a when, right? Of course, we do all the things that we talk about, hand washing, vaccines and everything, but unfortunately we don't have vaccines for everything. And, the most common types of breathing problems we see are from viruses, as I mentioned. On rare occasions, they can be caused by bacteria. And for most kids that enter the ICU for breathing issues, they are on what's called high flow nasal cannula. And I hope that this gives some peace of mind actually to parents, because high flow nasal cannula is what it sounds like. It's just a nasal cannula. So one prong in each nostril. And what high flow allows us to do is give a higher rate of air that's nice and humidified, so it doesn't actually bother their noses as much as even a normal nasal cannula. So that allows us to deliver more oxygen at a higher rate, and it's nice and humidified. And I would say 80% of the kids just need high flow. Then we step them down to normal nasal cannula, send you to the floor, regular pediatric floor, and then they go home. For some kids, they need a little higher support, and for them, we put BiPAP on them, which is a mask either completely over their face, over their nose and mouth, or just over their nose. And what that does is it helps with each inhale and exhale. So it just supports their breathing. Sometimes your kids need a little bit of a medicine to keep them calm while they're on the BiPAP, because whenever parents ask me like, how does it feel like? I say, well, I don't actually want them to do this, but if you stick your head out of a car when it's moving over 30 to 40 miles an hour and that air is coming at your face, that's kind of what it feels like. And that sounds really uncomfortable, but what I will tell you, and I tell this to parents as well, if you ask a teenager who can talk to you and, can really you can reason with, 9 to 10 times out of 10, they're like, I feel better. And they actually want it on them. So it really does help with their breathing. And then on rare occasions, what can happen also is a breathing tube. And that's where we make sure that your child is completely asleep and not feeling anything. We put the breathing tube in, and then we help them breathe with the ventilator. And your kid is sedated throughout that experience. Some kids don't need a lot of sedation, and actually holding their parent's hand is the best thing for them, more than any of the medications we can give them. So I definitely encourage parents always to be participating in their care. And I know we'll get into that, but I know I talked about breathing problems a lot because that honestly is probably 80% of the ICU. Other things we see are, of course, we see infections, and the infections that end up with us in the ICU are septic shock. And that means that the infection has gotten so bad that, your body is just not working in the same way. So you come up to the ICU so we can support the body and treat the infection. And when I say support the body, I mean giving them medications to help maybe with their blood pressure. We give them extra fluids. And of course, we give them antibiotics. And most kids turn around just fine. And I would say maybe the last most common thing that we care for in the ICU is trauma. That can be from motor vehicle accidents most commonly. Of course, it can also, unfortunately, in this day and age, we do see gunshots. Of course, super, rare. I wish it was more rare to me, but it's not. Of course, normal falls and things like that. So we do take care of a lot of those. And lastly, I should mention this is post-op. So
Yeah.
if your child needs a surgery, there are certain surgeries that are always cared for immediately after the operation in the ICU. I don't want parents to worry about that though, because your surgeon will always tell you. And most frequently, neurosurgeon or brain surgery, not surprisingly, comes to us. And then they always do well. They almost always do well, and they go right to the pediatric inpatient floor.
Ooh, and I love the way you broke down the respiratory distress and also what sort of modalities are there, because that's something that a lot of my followers are surprised about, when they're like, oh my gosh, I got into the ICU and it was all this hoopla of like people coming in and putting all this stuff on my kid. And it's so helpful. And obviously, besides that, IV lines and other, things to just give fluid support and all of that.
Yes.
Is there anything else that, a family can expect that may be on the child besides, if they're a respiratory distress situation to kind of, normalize those?
Yes, absolutely. So thank you so much for mentioning an IV line. You're absolutely right. If you're in the ICU, you have an IV, unless you're on the tail end of your disease. And in those circumstances, I'm actually very free with you don't need it anymore, so we can take it out because
nice.
To free the kids.
Yeah, I know. Even as a 35-year-old, having an IV when I was postpartum, I was like, get this thing out of me. So
I know,
I give these kids a lot of credit. It's hard. It's not easy having all this stuff on you. Yeah.
It's not. And it also means, the other thing I should mention, since we're talking about IVs, is parents, don't be surprised. We often put it almost looks like a splint if the IV line is in a hand, and that's just so that your kid can't move their hand around and dislodge the IV. So nurses are sort of the heroes who have these magical ways of dressing IV lines, but do expect that. One tip though is if your child has sensitive skin, please tell the nurses and doctors, because there are different types of tape that we can use. We always like to use sort of stronger tape so that it doesn't fall out, but we absolutely switch to more comfortable tape when a parent tells us that their child has sensitive skin. The other thing that you should expect is if you're in the ICU, you'll definitely have leads on your chest, which are just stickers, and that allows us to monitor breathing, your heart rate, and those are the main things that those leads do. And then in some circumstances, particularly if you have a breathing tube, we might place what's called an esophageal temp probe. And all that is a tiny little tube that we put right next to the breathing tube just to get a continuous temperature as well. I think besides those are the most common things I would say. But the only other thing I always tell parents to expect is, there is going to be a lot of beeping, unfortunately. And, there are units, ours is one of them here, where we really try to minimize the number of alarms because it obviously bothers patients and their families. But it is an unfortunate side effect of being in the ICU that there are a lot of sounds. And I just would say to parents, try to just let go of the sounds of the monitor because there's so many. Sometimes it's real, sometimes it's not. But if your child is on a monitor in an ICU, I want you to be comfortable knowing that there are doctors and nurses that always have eyes on that monitor, even if they're not inside the room. And I think that's a really important thing for parents to understand. Because I know sometimes parents can feel a little lonely in the rooms, and I totally get it. But we're always watching.
Yeah. Oh, I know and I've been in ICUs too, and not like higher level
I know you
care.
have.
And it's been, I not that it makes it any easier if I ever watch my child go through it or if I go through it again. It is really hard. The lines, the beeping, it's like noisy, and you're just trying to rest.
It's
but
super noisy.
Like you said, I know it needs to happen, and I know it can be frustrating for everyone listening, but it's for a reason. There's a method to the madness here. Yeah.
It is. It really is. And I will say this, becoming a mom myself, especially after having Sita when I first came back, it completely changed how,
I'm sure.
I mean, I think as an ICU attending, we start to, the common easy patients, like the high flow patients that I was telling you about, those are the quote unquote easy ones in the sense that we kind of know how they're going to do. They're going to get better with time. So not that I wouldn't talk to the parents, but I maybe wouldn't talk to them for half an hour to 45 minutes.
Right.
That has completely changed as a mom, because I know if I was that mom in the ICU and I had no medicine in my brain, I would just be sitting there shell shocked.
Yeah.
So I do want to empower parents. Like, the care team is always there in an ICU. Most ICUs have 24-hour doctors. If you ever feel like you need to talk to a doctor, you tell the nurse. And I tell that to every single one of my patients. Just because I'm not here doesn't mean I'm not available to you. Just tell the nurse and they know how to get me.
And
so it's hard.
Yeah, it is. And, I know you talked about obviously the things on the child, but what else can a family expect during their admission? Like how workflow happens.
Yeah.
And I know this can vary from ICU to ICU, but sort of things that you wish parents would know before they came in on how things happen and work there.
Yeah, absolutely. Also, I'm just realizing I am wearing a jasmine necklace that my daughter gave me this morning.
Oh, so beautiful. I love it. Oh, I love it. Mom
Okay,
work
so
life. I like it.
Exactly.
Yeah.
I promised her I'd wear it. I keep my promises.
Oh, I love it.
So things to expect. So most ICUs in this day and age do family-centered rounds. And what that means, and I'm using this term very specifically because I think all parents should ask when they get there. Do you have family-centered rounds? And what family-centered rounds is when the entire care team rounds, and the care team at the very least includes the attending, maybe a PICU fellow. A fellow is someone who's completed their pediatric residency and is training specifically in ICU. And you'll have likely a pediatric resident. You will have the bedside nurse. You may or may not have a charge nurse. You may or may not have a pharmacist, a nutritionist. We're lucky here. We have all those services. So you're going to see a lot of people, and they'll invite you outside. And what they'll do is they will present your child. They'll probably use a lot of medical terms.
Yeah.
So what I would say is allow them to finish their stories about your child. And once they're done, or you can even ask when is it an appropriate time to ask questions, they'll tell you. And then ask the questions. And what I tell this to every family too, bring in a pen and paper. Whenever questions pop up at any time, whether it's at 3 a.m., write it down, because one thing I'll promise you is the first time you see that big crowd of doctors and nurses, all your questions are going to sort of go out the window. So I feel like we should give every family a pad of paper, because honestly, write things down, ask questions. It's your job as a parent. You're not bothering us. And that's an important point. You are not bothering us. You are helping us care for your child. And, another thing I tell every family is, your child better than me. I know medicine, but you know your kid. And parents do. They really do. They always do. And I always ask their guidance when I'm titrating sedation, like, how does your kid do with this? That, so I say all this because, I know a lot of parents can feel really helpless in the ICU, but on rounds, first of all, you are a participant in rounds. You're not a watcher, and you should feel empowered to participate when it's your turn. Generally, that's after everyone is gone. But even beyond that, like if you know your kid and you know that they like to lie on their right side, and you notice that when they're lying on their left side, they're getting a lot more sedation, you tell the nurse and the care team, hey, my child likes to lie on the right side. And that's the best information you could give me, because then we turn them on the side they prefer. Kids are still kids. They're still going to prefer what they want, even when they're sick. So all those little tidbits really help. Also, parents bring in their favorite stuffy from home, their favorite blanket, normalizing that room as much as possible. And then, another thing that they should expect, particularly when their kid is getting better, is we're pretty strict here as much as possible about opening the windows opening the blinds during the day, or keeping the lights on during the day and turning them off at night. If you hear the care team harping on that, it's because we're trying to prevent your child from getting confused. And there's a term for that called ICU delirium. So that's another thing to expect, is that, there are certain things that we do in the interest of your child, although sometimes, I know it can seem in the moment like, my child just wants to sleep. And we're like, yeah, but we want them to stay awake right now. So,
Yeah.
there seems to be conflicting things, but I promise you they're not as conflicting as they sound, I guess.
Yeah, and you mentioned already that you want families to be involved in the rounds, and obviously that how scary it can feel when all those people walk in. I mean, I don't know if people are familiar. So when you're in residency for pediatrics, everyone in residency has to rotate through the pediatric ICU, the neonatal ICU, the floors. And then some of us, like Anita, Dr. Patel, decides to go into fellowship for 3 years, right? So myself, even though I'm a general pediatrician right now, I went through the pediatric ICU rotations. And so I can attest to that. We all walk in, there's a pharmacist, there's 3 residents, there's medical students, there's a physician, there's the outgoing team, the ingoing team. I mean, it can be like 8, 9 people sometimes, and it can feel very daunting when they all show up in your room. And, Ryan was in the NICU, same thing happens in the NICU.
Yeah.
And I love that you said that, because people may not have that medical brain and that medical knowledge. So it can feel so overwhelming when all of a sudden they're throwing out, they're on high flow. This is what happened with their ins and outs, like overnight. You're going to hear all this terminology. And I love that, you said that, just ask the questions and really just say, hey, can you explain to me and they should, right? I mean, I think after rounds,
they're supposed to.
Yeah. They should, I've never been on rounds where we don't turn to the family and then say, hey, let's talk about this in a way that everyone understands. How, if you, could tell everyone in a way, what would be those questions you would want families to ask? Maybe these are questions that you never get asked and you wish they would, or maybe you just want people to know, like, hey, these are really great questions to ask your care team.
Yeah. So I think, first of all, asking what is your child being treated for? I know that sounds like such an obvious question, but sometimes I truly feel like parents are afraid to ask because so much is going on. So just asking the general question, why is my child here? And what are you guys doing to treat it? And I think starting from the place of, okay, my child is here for XX issue, and this is what they're doing to treat it. The next question I would ask is, what metrics are you guys looking at to determine when my child is starting to improve? And the reason I like that question over the question every parent asks, which is, when is my child leaving the ICU?
Yeah.
Of course, I'll give them an estimate, but I give them an estimate along with, just so you know, the metrics I'm looking for are, I want your child to be on normal nasal cannula while asleep, and doesn't have a desaturated, the oxygen doesn't drop while asleep on nasal cannula. That's when I know your child is ready to go to the regular inpatient floor. So in that way, they understand why the kid's there. They understand what we're doing to treat it, and they understand the metrics to watch for when I know my child is getting better.
And I love that you mentioned that one thing, because I think sometimes there's an assumption from a lot of parents that just because you're in the ICU, you're going to get discharged from the ICU and go home. But a lot of the times it's getting downgraded to a regular floor bed because you no longer need that ICU care, and you may need to be in the hospital for another few days or whatever it is. So there's a whole process here, guys, okay, here you're going to go here. And sometimes you get admitted to the floor, which is the inpatient non-intensive care. And then you get transferred, which during respiratory season, I know that very familiar as a resident, how many times we have to go and assess the child and say, okay, now they're going to the ICU, or then I have to do a, transfer or get the transfer from the ICU. So there's a lot of logistical things that parents may not understand. And I love that we're talking about this, because it can help just not feel isolated and fearful of the process, and just know that we're obviously doing everything in the best interest of the family and child.
Yes, that's exactly right. And I would also encourage parents to ask, what medications are being administered to my child. I do think that there's a lot of fear in some families. I don't want to be the difficult family. I just want to empower you that asking questions is not being difficult. And if anyone makes you feel that way, they're in the wrong, not you.
Mm-hmm.
There might be circumstances where, the nurse or doctor says, I can't give that to you right now, but I'll come back. And that is an appropriate response because there might be someone who's a little sicker that needs their attention. But really asking, I think the more information parents have, and I will say this, my chart and portals have really improved a lot of that.
Mm-hmm.
But asking, which medications your kid is on is also really important. Another tip that I should have mentioned in the beginning, if your child is on any medications at home, I always encourage parents to bring them in. Not because we're going to use them, we're going to use the hospital meds, but that way you don't forget, especially for kids that are on a lot of medications. It can be really difficult for parents to remember everything. So, that's
names,
just,
frequency, all of that. I mean, it's a
yeah,
lot for
it's too
anybody.
much.
Yeah.
It's too
Yeah.
much. It's too much. So yeah. So just to empower you to just remember to grab those before you go.
Yeah, this is so wonderful. I just love that we've talked about so much of the experience there, and you speak about it in such a positive way, which I so much appreciate because I think there can be a lot of fear around the ICU, and of course, it's not easy. I mean, I don't think either of us are ever going to say that, oh yeah, whatever, it's not a big deal. Of course, this is a big deal. So now,
Yeah.
my question for you, being a mother now of 2 children.
Yeah.
You mentioned already that after CETA, you came back and you spent a little more time, but how has being a mother, or even maybe before being a mother, how has it impacted your anxiety? Because obviously you are seeing things
Yeah.
that are very unfortunate, right? We see a lot of healing
Yeah.
in children, but there's no denying that you see a lot of sad stuff or things that you're like, wow, this could happen to anybody. How do you manage it? Or maybe are you even managing at this point?
I think I'm managing it now.
Yeah.
I will say this. So a little backstory on me for people that don't know is I had my first child, Sita, a month into lockdown,
Yeah.
into the COVID lockdown. And so because it was such a new disease, and despite what the media was saying that kids don't get it, we had an ICU full of kids and a lot of them had it. So, reason I'm mentioning that is because I absolutely had, a disproportionate fear of COVID and
Mm-hmm.
my daughter getting it. And not to say, none of us knew what was going on then.
Yeah.
So I give myself a little bit of grace. But I know that my isolated experience in the ICU definitely affected my general view of the pandemic.
That makes sense.
Um, and even when I realized it, I also just had to accept. And so, Mona, to answer your question, I think just knowing when my experience is affecting my judgment has absolutely helped,
Mm-hmm.
to understand what is rational and what is, I hate using the word irrational, but what I'd like to say is clouded by my ICU experience, I guess. So in that way, when I know, so another example is, I definitely have an over exaggerated fear of my daughter walking across roads
Mm.
because of what I said, trauma, right? And I unfortunately see a lot of kids that were hit by cars or kids in cars getting hurt. So, I would say that's one of the fears that has actually served me though, because she's not terrified of crossing the road, but she reaches for my hand.
Right.
There's no way she's not running across the road because I've been so crazy about don't do that. But in general, I have realized I see when my experience is clouding my judgment, and I have been able to overcome that. So just knowing, okay, this is not a reality. This is really just my judgment based on my
Yeah.
experience, allows me to sort of walk through it. And I'm seeing that in real time, not to say that I'm throwing caution to the wind with COVID, but we absolutely are having a birthday for Sita, and we still do activities with her indoors.
Mm-hmm.
We make sure she's fully vaccinated. We do all the things that, are dictated and we know that will help protect her against severe disease from anything. But we are living life. And whenever I think about what I'm doing, and if I start to get fearful about it, whether it's from an infection reason or a whatever other reason, I say to myself, is this going to bring joy to me and my family? And if the answer is yes, I go through it, eyes open, that,
Yeah.
rare things happen, but they happen rarely.
Yeah.
And that's like my mantra, rare things happen rarely. So I was a long-winded answer. I apologize, but
No, I love it. I think it, and also it's obviously it's bringing back memories of 4 years ago now at the time of this recording, and me and you had spoken a lot in the pandemic, and I love that I'm having you come on because you saw the worst of COVID. I actually saw as a general pediatrician children heal from COVID, right? So I loved being able to speak with you because we were able to bring a middle ground, right? Like I would say, hey,
absolutely,
I'm seeing a lot of healing. So I don't want us to feel this sort of, oh my gosh, it's a horrible thing. Obviously it's a threat, but that's that perspective, right? That's what I saw because I'm outpatient. So I would see kids come in, but I'm not seeing the kids who get admitted. So of course there's going to be perspective. I use the example, like my husband, as you know, and a lot of my listeners, my husband's an ER doc, not even just from COVID, but my husband is never going to go on a jet ski because the things that he sees happen on a jet ski, he will I'm never setting foot. And I used to jet ski back in California all the time. Like it was such a fun thing. I'm like, sweetie, you're seeing intoxicated jet skiers that aren't really mindful of the things. So that's your bias there. And he's like, there's certain things as an ER physician that he will never do because of the things that he sees. And I'm not going to make him do it. Right. He's like, listen, I just will never get on it. Like I won't do it. Like motorcycles, he will. And I also would never, but he will never get on a motorcycle. Like he will never. And every time we drive by a motorcycle, I think he has a little bit of PTSD because he's like, that person's going to end up in the hospital, and he gets so nervous about it. Both of us are doing EMDR therapy for all of this trauma that the pandemic caused. And I don't think you are, but I am floored with how much it's helped me with not even my birth trauma, but all this micro trauma, like the pandemic was trauma, right? And also this, like my husband having to go back into the thing. So, when people ask about how I manage health anxiety, I love to hear how other people in the specialty and field have managed it, but understanding that there's nothing, like you said, not getting mad at ourselves for ever feeling that because we're trying to protect ourselves and our family.
Yeah. And Mona, I do have to, and I'm very public about this. I'm not doing EMDR, although I have looked into it. I am in therapy. I have been in weekly therapy since my last year of fellowship. So that's 8 or 9 years. And, if I didn't have that, I would not be able to know when my judgment is clouding things. So the only reason I can have that perspective is because I have been and am currently in therapy. I feel like it's like a requirement for all physicians.
I mean,
to make
I
sure
feel like my husband says everyone needs a behavioral therapist or a therapist, like everyone. But you think absolutely. About anyone. I mean, any parent, because how much of this affects us, right? And thank you for being open about that. Because not only am I happy you're open about that because of just being a female in medicine, but because we're talking about this whole experience. We're talking about families coming into the ICU. But as you know, I love sharing compassion for caregivers like ourselves, like wanting people to understand that we, as your caretaker for your child, also deal with the vulnerabilities that we're seeing of you and your family. I mean, to take that on every day for you. I think about you. I think about my husband. Like Jen needs, I see a lot of sad things too, but not nearly as much as my ICU colleagues and my ER colleagues that deal with trauma and the fragility of human life coming through your doors every day, And so thank you for doing that work.
Thank you. I mean, honestly, I don't see it as a choice. It was like the second I walked into the PICU as a resident, I was like, oh, I guess I'm doing, and I had already applied for a different fellowship, and I was like, well, this is what I'm doing. So I just knew. And everyone tried to convince my parents, especially, but I'm lucky. I feel like the luckiest person, and that I love it. And we were talking before. Sometimes when I'm going through a really difficult time, which I am going through a hard time right now, honestly, I feel better in this moment, obviously talking to you because it's fun to talk to you. And I'm also in the hospital, and like, getting to take care of patients and parents. Let's be honest. I don't just take care of patients. The ICU doctor takes care of his parents too. And parents, just so you know, you are our responsibility. It's not just your kids, really. And I mean that. So.
Oh, well, I cannot wait to give you the biggest hug when I see you. I cannot wait. Like the hug is gonna like be so therapeutic because we're just gonna connect over having pandemic babies, the IVF.
Exactly.
I might
IVF.
Listen,
I know.
we've been through so much, and I really appreciate you coming on and talking about this and really empowering parents to be, you know, their advocate for their child in the ICU. The questions that you pose for them are so important. And also just the way that you just lined up everything, you know, what happens with oxygen support and the things that are going to be happening. I just hope everyone listening, if they find themselves in the ICU, and maybe you're going to be listening to this, everyone, when you're in the ICU, maybe you'll be like, I remember Dr. Mona and Dr. Anita, they did a podcast, and I hope our calming voice and our, you know, understanding of what's happening gives you some peace as you watch your child heal. So thank you so much for joining me today.
Thank you, Mona.
And where can everyone find your social media to stay connected? Share that with us.
Yeah. I am on Instagram, just like Mona, at Anita K. Patel MD. So that is my best place to reach me.
Yeah. And, you know, Dr. Anita, she shares a lot of the perspective of being a mom in medicine, behind the scene parenting stuff, similar things to what I do. Obviously, a lot of health information, evidence-based information. So I love, you know, obviously I love following her. And like you can hear from her words, a compassionate physician, which we need so much of. And the system can break us, but it's not going to break us. We're going to have control.
No, it's not going to break me.
Well, everyone listening, if you love this episode, first make sure you follow Dr. Anita on Instagram. I'll be attaching that to my show notes. But like I mentioned at the beginning, make sure you leave a review or a rating because it's how this show continues to grow because we can reach more people that way. And I cannot wait to chat with another guest next time.